Everyone, and thank you so much for joining us tonight for this webinar about biomechanical taping for movement and control. Before we get started, the upcoming ASHT webinars are listed here. We have one next week about MP and PIP implant resection arthroplasties, and then another one about the Medicare updates coming up on December 5th. We're very excited to have Ryan Kendrick here with us tonight, and we are excited that Dynamic Tape is sponsoring this event. A few housekeeping things. Please close additional programs on your computer. This might delay some things and provide technical difficulties. You are encouraged to ask questions at any time. You'll use the question box on your screen, and then I, as the moderator, will ask the questions out loud for everybody at the end of the presentation. A quiz will be emailed to all participants within a week. If you have not received this within a week, please check your spam folder. Certificates are available upon completion of the quiz. Please respect the presenter and remember that this is his material and may not be reproduced without his permission. So I'm honored to introduce Ryan Kendrick. He is a musculoskeletal physiotherapist who has worked in both the United Kingdom and Australia. He's been a PT since 1994 and has worked extensively in elite sport, including roles as a physiotherapist for Essex County Cricket Club, a personal physiotherapist to Greg Rudetsky in the ATP Tour and the British Davis Cup team, and many Olympic, Commonwealth, and professional athletes in various athletic pursuits. He is the developer of Dynamic Tape and has taught clinicians and athletes about Dynamic Tape in over 25 countries. Thank you so much for being with us tonight, Ryan. Everyone, please hold for a second while I change the screen to his.
Okay, thanks very much, Hannah. And thank you very much to the ASHT and everybody involved in organising this event tonight. I appreciate the invitation and welcome to everybody else who's listening in. We're just saying it's a little bit of an unusual format for me. Generally, we're teaching taping sort of workshops live. So I think also today we have a lot of different experiences or different areas of expertise, I guess we'd say. So the aim is sort of not to really just give you a list of or a recipe of techniques, but really to help you understand where this tape fits in, particularly for those of you who aren't familiar with the dynamic tape and just how different the properties are. So I'll give you a little bit of a background as to where it came from, to give you a good appreciation of where it fits in and where you may find this useful compared to some of the other existing products. And also to give a foundation so that you'll be able to develop your own techniques that are going to be specific for your patient population and your treatment approach. So in doing that, I will go through a number of techniques that sort of illustrate some of the key points, some of the key mechanisms behind how we use the tape, some of the emerging research that's coming out demonstrating some of those effects, and so on. And of course, if you have any questions, as Hannah said, please type those in and I'll be only too happy to answer them as best I can towards the end. So we'll just move on. As Hannah said, a lot of my work has been with elite sport and professional athletes, and I guess from my point of view, that's where the idea with the tape came from. Well, we were trying to create this effect with other things, with some, I guess, some varying sort of results really. And I must also give credit to my wife, Ilva, who is also a physiotherapist and who was coming at it from a pediatric and sort of neurological perspective. So between the two of us, and then in collaboration with some of our colleagues, we've sort of continued to refine the tape to do what we wanted. And if I sort of talk in terms of the sporting population where I was based, what we found was we had a lot of those over use, or probably more correctly, our overload type of injuries, our tendinopathies, our running injuries, our throwing injury type things. And so we were always looking at trying to manage the load. We know that load is a critical factor in the development of many of those conditions, for example, tendinopathy. But we also know that load is essential for recovery, but that we have to manage it fairly specifically. And so, we would be looking at things like equipment, things like the environment. We might take people, say off running hills and put them on a flat surface or something like that. With the equipment, we might change the weight of a tennis racket, or the size of the grips, or the strings tension, or various things that we could do with equipment to modify the amount of load that they had to endure or dissipate. Obviously, a training program, or the overall amount of work that people were doing, and making sure that they had adequate adaptation periods and recovery periods to allow to build capacity within the tissues themselves. And then also, looking at movement, looking at biomechanics. Now, there's not a lot of great evidence to suggest that certain movements are causative of various conditions, but there's certainly correlations there, and there's certainly we certainly know that certain movements will load certain structures more than other movements. So, often we were looking at, once there was an injury, that we could manage the load on that injured structure by changing the way that people were moving. But certainly for function, looking at the way people are positioning and moving is really critical. They may not have a pain issue. It may just be purely a functional issue. Somebody may have a nerve injury and not be able to overcome, gravity acting on the weight of the body, whether it's something like a foot drop, or whether it's somebody's wrist and they can't position their wrist into extension because they don't have that active extension. So, managing load, managing movement patterns, whether it's a technique in a sporting environment, looking at a performance aspect, or whether it's looking at function for somebody else. So these were the sort of things that we were trying to do. And just to give you a heads up on those who haven't seen the tape before, it's essentially, in simple terms, you can think of it a bit like a bungee cord or a spring that we can put on the body externally to try to create some of the deceleration and load absorption, and then this strong spring back the other way to provide an assistance. So let me just start going through, I guess, a few of the basic approaches, or the traditional sort of taping approaches that we've had. And broadly, we can sort of categorize this as a biomechanical approach and a neurophysiological approach. And there is a lot of overlap, but just for ease of discussion, we tend to just sort of separate those out. And so with the biomechanical approach, what we're generally looking at doing is trying to use the tape to maybe restrict motion, or certainly to resist motion mechanically, to change those movement patterns or to change positioning. And we generally think about that with our rigid athletic tapes type of thing, but also our elastic adhesive bandages, things like our Coban, and also to a lesser extent our kinesiology tapes. And I'll explain a little bit about that in a few minutes. If we look at the research with regards to this, there's not a lot of great systematic reviews and things, largely because a lot of the studies are looking at different treatment techniques, different outcome measures, different patient populations, and so on. So there's not a lot of similarity there to be able to pull data to give us a lot of any meaningful sort of, or draw any meaningful conclusions. There's a little bit, some of the areas of the body that have been done a little bit more, the patellofemoral joint and some of the arch type tapes in the foot as well, but that's taking us away from the upper quarter a little bit. But what we do see, though, if we look at some of the individual studies when taping in this way, is that we do see some nice changes in things like our muscle activity, movement, 3D kinematics, joint position, plantar pressures in the foot, range of motion, and so on. generally with those rigid tapes and the elastic adhesive bandages. To a lesser extent, these effects gained with weaker elastic tapes, like our kinesiology tapes. The second side of it is where we're coming at it from a neurophysiological perspective. And so here, what we're really trying to do is have an input into the system via the tape's contact with the skin to potentially have an effect on perhaps the pain system, perhaps the motor control system. Maybe we can, change proprioceptive input as well. And then also, I guess it is slightly more mechanical, but looking at mechanics from a tissue level is perhaps can we also improve the lymphatic drainage and that sort of thing. And again, these days, I guess we probably think about this more with regard to kinesiology taping, but we've sort of done this for a long time, with our other tapes as well. Many of you might have, say, taped for scapular sort of positioning, perhaps with your coverall and then your rigid tape over the top, maybe for lower trapezius, sort of running along the lines of lower trapezius. Or you may have taped sort of over the top of the shoulder, over the upper trapezius and levator scapulae to try to get a bit of an inhibitory effect. And the thinking behind that was generally that if we taped along the line of the muscle fibers, that we would be getting a more of a facilitatory effect, and if we sort of taped across them, we'd be getting more of an inhibitory effect. And some studies have looked at that more recently. Dr. Carolyn Alexander, actually out of London, and her group have looked at that, and they actually examined the Hoffman reflex, so looking at that motor neuron pool excitability, if you like. And they actually showed that taping for lower trapezius, so taping along the line of lower trapezius, actually resulted in an inhibitory effect, not a facilitatory effect. And they found that taping across the lower trapezius didn't change anything. So that was sort of contradictory to what was sort of believed beforehand, I guess. And that's not to say that when we tape somebody in that way and they, move their arm, shoulder into abduction, and their pain was a lot better and their movement was a lot better. It's not to say that wasn't happening, but it doesn't appear to have been happening because of facilitation at a motor neuron pool level. They've also looked at that actually similar sort of thing on the calf muscle and shown the same sort of results. So, from my opinion, I don't think we have a great understanding of how to manipulate, say, these neurophysiological effects to give us best clinical advantage. We know that whenever we put a tape on, we change things. There again has been some studies just laying a piece of tape over the patella and looking at some of our functional MRI type of brain imaging studies. And they show that just by applying a little piece of tape and doing a knee repositioning sort of proprioceptive activity, that the brain lights up in different ways. So just having the tape on there changes things. But again, knowing how to use that to best effect, I don't think is particularly well understood. We seem to see some conflict in the literature where one study will show perhaps a bit of an facilitatory effect, and another one may show no change, or perhaps even the opposite. There seems to be differences sometimes in perhaps, different muscle groups may behave differently. They certainly have different function in terms of some may be more designed around movement and speed, some may be more designed around control and stabilization. So it follows that perhaps they have a different response to tape, and certainly a different response when they're in pain to when they're not in pain, as that tends to, we tend to see an inhibitory effect on certain muscle groups in the presence of pain and facilitation of others. So it may be that tape sort of has different results in different circumstances, and I just don't think that it's particularly well understood at this stage. What the systematic reviews on kinesiology taping generally do show is that there does seem to be a positive sort of effect on short-term pain relief, less conclusive on some of those other parameters around movement. There are individual studies that show some nice changes there, and again, though, they tend to be taping from a biomechanical perspective, though, rather than a neurophysiological one. And by that, I mean they're often putting them in a corrected position, putting a lot of stretch on the tape to try to create a restriction or a strong resistance to the movement. So you'll see as we go through tonight that we're sort of fairly heavily situated in that biomechanical category. And as I mentioned before, often we're looking at trying to manage things like load. So can we get in there and just apply something to the body externally, if you like, to create the force that's required to decelerate the limb, or to perhaps assist movement to overcome the load on the body from gravity, or from an external load. And so we're very much in that biomechanical category, and you'll see a little bit more as we go along how we can use it there and how it differs to what we might do biomechanically with other tapes. So our main aim then is to manage that load. As we mentioned, our tissues don't fail because of pain, they fail because of load, and we know that there's a very poor correlation between pain and tissue damage in any case. People can have a lot of pain, very little, if any, ongoing tissue damage, or they can have a lot of tissue damage and not a great deal of pain, or we can see, two people with the same sort of injury, same amount of tissue damage, if you like, and very differing levels of pain. So there are a lot of other factors involved, obviously, and we talk about some of those psychosocial factors and so on that can influence that pain experience. So that doesn't take away from the fact, though, that in many cases there is tissue damage, and that's what we're looking at dealing with, or there's a functional impairment, and that's what we're looking at dealing with directly. So with this tape, you'll see it, as I mentioned earlier, it's a bit like a bungee cord. So very strongly elastic, and you'll see the differences in that compared to, say, your kinesiology tapes or your elastic bandages or your Coban in a few moments. But what it allows us to do is create that strong resistance, deceleration of motion, and then that strong assistance back the other way. And that allows us, we can bring in some changes in joint positioning, joint movement, some of our Mulligan type things, if some of you are familiar with that, as well as controlling some of those gross movement patterns. But also, if we go circumferentially, because of the strong recoil properties of the tape, we can also get a strong compression, and that can be useful in creating or augmenting the stability at joints. So, as mentioned earlier, our focus is really on managing load, managing movement patterns, and managing function, not so pain-centric. As I mentioned, people may not even have pain, so that may not be our main aim. Secondarily, we do see nice effects on things like, bruising, swelling, and all those sorts of things. Obviously, effects on pain, particularly, if we're looking at a lot of our typical injuries, in the absence of sort of persistent pain states where there might be central sensitization and other things going on from a psychosocial perspective, but often in our more acute injuries where there is tissue damage, there is nociception, there is, inflammatory mediation and so on. Those things the pain then tends to be fairly load dependent. It may vary from one person to the next for the same amount of tissue damage, but basically the more you load it, the more you stretch it, or the more you push on it, the more it hurts. So by managing load, we do tend to manage their pain as well. Okay, so when it comes to managing load, we used to run into a few issues with our products that we had available, and we never sort of set out to start a tape company. That was not on our radar at all, actually. But we were trying to create the effect with whatever we could get our hands on, whether it was taping TheraBand to people. We would cut the inner tubes of bicycle tires and tape those to people, but we couldn't really send people out onto the tennis court with that sort of stuff taped to them. But what we found was, with what we had available, that we would often be getting a restriction of range of motion. And in some cases that was the aim, but often that restriction then became disadvantageous. So we would tape up our tennis player's shoulder, send them out to hit a few serves, and they would just come back and say, look, I can't get into the positions that I need to create the or to do the serve or to do the technique that they needed to, or it was very uncomfortable, and they would end up just pushing through it, and eventually it would just come off, or fairly quickly would just come off anyway. So that was the first issue. The second issue is that when it comes to managing load, movement is the biggest way that we dissipate load, and we often move over multiple motion segments to deal with that force that's being applied to the body. So, for example, if we have a baseball pitcher, pitching a ball, they don't just stop once the ball's released from their hand. They obviously follow through and step through and rotate their trunk and flex at the hip, and as well as all the upper limb movements that are going on. So we dissipate that load over multiple motion segments. If we start to restrict range of motion at one of those motion segments, the same load still has to be dissipated. So we start to shunt those forces around, and there is potential there to change what's going on elsewhere, possibly increasing problems or risk of problems elsewhere. There has been some studies, for example, looking at rigid taping and bracing on the ankle, and showing that during hopping tasks and landing tasks, that it does in fact change the force vectors and things going on at the knee. So there is that aspect to it as well. And again, going away a little bit from the hand, but when we're talking about the foot and ankle again, if we lock that up, we also reduce our most finely tuned balance strategy, which occurs around the foot and ankle, to maintain our balance. The other thing that we had, or issue that we had, was that we didn't actually get much in the way of deceleration through the range of motion. We could create a bit of a block and a change maybe of our passive endpoint to motion, but that didn't give us a deceleration through the entire motion or through the entire part of the movement that we were looking at. So, for example, a pitcher, once again, once they release the ball, we may want to try to create some of the deceleration force for them. They tend to get a very high posterior capsular distraction forces in the shoulder, for example, and so we can create some of the deceleration. Then not all the work is falling on those structures, so we can take some load off in that way. And then the other side, or the continuation of that, is that with a rigid tape, for example, there's no active component to it. It's not assisting anything. There's no spring back, if you like. So we wanted to be able to both decelerate during that lengthening phase and then use that stored energy to come back and spring back again to provide a functional assistance to motion. And then lastly, which is a big issue, particularly with rigid tapes, is this idea of tape fatigue. And what that means is that whilst we might see some nice changes initially, those changes tend to be fairly short-lived once we start loading it up fairly significantly. Now, again, a lot of the work in this, research-wise, has been done on the lower limb, but if we look at something like an arch support tape, we know that we can see very nice changes in the height of the navicular. We can see very nice reductions in the generally excessive activity or overactivity in the tibialis posterior, tibialis anterior muscles. But if we then put somebody on a treadmill and have them jog for 10 or 20 minutes, that effect tends to diminish pretty quickly. We can make it last a bit more by reinforcing the tape in various ways. But basically with those rigid tapes, particularly once you start pushing into them, they tend to start just giving and loosening off a little bit. And particularly once you have moisture involved, whether it's somebody sort of in the water or if they're perspiring, then the tape tends to give, and the effect doesn't last as long as we might like once they're exercising or it's under considerable load. So in order to get the mechanical sort of effects that we're after, we have to sort of tape in a particular way, and it is quite different to what we do with other tapes, both to deal with the large forces so that we don't get issues with the skin breaking down, but also to get a mechanical effect. Now, this applies with your rigid tape as well for most of these things, but the first thing is to get a mechanical effect, our tape has to cross over a joint, at least one joint, possibly multiple joints. So we've got to extend the tape over the joint, basically attaching to either side, if we hope to mechanically affect motion at that joint. The second thing is that the tape has to be applied with the joint, or perhaps the muscle, if you like, in a relatively shortened position, or perhaps a corrected position if it's a rigid tape, such that as lengthening commences, that the tape is going to create some resistance by stretching as that lengthening occurs. So I'll just skip over for just a second to a short video, and then I'll come back to that. So this sort of gives you the idea. If we think about our bungee jumper, if we've got the tape applied in a short position, then it's going to stretch and provide resistance, deceleration of motion, load absorption, if you like, store the energy and then re-inject it. But in the lengthened position, there's not much deceleration, as you can see there. So he's hitting the water pretty hard. The tape, the bungee here, you see, doesn't even have an opportunity to stretch and create that deceleration of motion. So if we want to be getting a mechanical effect, we've got to cross over that joint. We've got to get it on in a corrected or a relatively short position, such that there's going to be a resistance to motion when it's required, or when we want it to be occurring, just like our bungee jumper there. And then lastly, and this is where I think a lot of techniques tend to break down from a mechanical point of view, is that we have to be able to get good purchase on the levers, or get hold of the body part that we're trying to affect, if you like. And so what you'll see if you watch some of our videos and things is that often we're doing spiraling type techniques, where we'll spiral around a lever, to take up the soft tissue tension, so that we can actually get very good mechanical resistance to motion. The other ways that we'll often do it is we might split the tape down the middle and pass the two ends around a lever to grip hold of it, or possibly cut a hole in it and pass it over a finger or a thumb to once again get hold of that body part, so that we can actually get a good mechanical effect out of it. All right, so this just gives you a quick idea of the degree of energy absorption and so on that we can get with the tape. So I apologize here, we actually look at the left hand without the tape and the right hand with the tape, just for ease, but you can see the resting position of the wrist there, and then you'll see what occurs when I start to move the arm. So you can see the wrist bouncing up and down. We're not really getting even to the sort of neutral position there. It's just sort of going up and down. Once we tape it up, you can see the resting position has changed quite significantly. So now resting just under the neutral position, or under the horizontal. The fingers obviously are resting in extension. And you'll see as we start to move that now that tape is stretching as it goes into flexion and then recoiling, and we can see a much greater movement there, such that it's getting a bit hard to control. I've got to control the elbow there. But we're getting this strong energy storage, absorption, storage and release into the system, and changing the movement quite dramatically as a result. So in order to do all this, the properties are quite different to what we find in our other products. And this table just sort of outlines or summarizes some of those. So it's made from a completely different material to our rigid tapes, which are often a cotton and rayon based type of product. Our kinesiology type tapes generally are cotton, plus or minus a little bit of lycra in some of them. And the big thing is, though, that if we want to be able to get the tape on in a short position and still get through full range, so it has to stretch a long way. So it stretches much further than say a kinesiology tape, which is quite often applied in a more lengthened position. And the other big factor is that it doesn't have a rigid endpoint. So if you are playing around with the tapes, if you feel your kinesiology tape, you'll find that when you stretch it, it has a rigid endpoint. And that can provide a nice mechanical restriction to motion in some cases. But our aim here is to provide this strong load absorption without the resistance to, or without the restriction of motion. And so if you apply your kinesiology tapes in a short position, often what you'll find is that you'll hit that rigid endpoint and it'll start to restrict motion. Also, your kinesiology tapes only stretch longitudinally, so what we'd say is two ways. They don't stretch transversely, which again has important implications for your kinesiology taping or methodology. But from our idea of not wanting to limit anything, we do need the tape to stretch in all directions. We also, if we're crossing tapes, we don't want a tape applied over the top to be restricting the recoil of the underneath layer if it's, you know, if it's perpendicular to it. So the top layer needs to be able to stretch in all directions to stretch with the underneath layer. We also move, you know, in three dimensions or multiple planes of motion. So we want the tape to be able to stretch in all directions. So if we are spiraling around or we are crossing the midline and then the person's twisting or turning, that the tape's not going to create any restriction of motion. And also it's not going to create, or it's going to reduce the tension points on the skin as a result, and hopefully reduce the risk of getting reactions there. And also our muscles aren't all just longitudinal, you know, they have different angles of pennation of muscle fibers. And so by having a tape that stretches in multiple directions and recoils in multiple directions, we can sort of more closely perhaps mimic the muscle function or muscle action. So our aim is mainly around that, as we said, managing load, movement, function, decelerating movement or assisting movement. We do see nice neurophysiological effects, effects on bruising, swelling as well, but that's sort of our primary aim, if you like. So this video just shows you quite clearly the differences in the properties. I'll just let this run for a moment. A quick demonstration. So here I've got a force gauge, a smart handle, and this measures the amount of resistance that we can create. Usually use it with our resistance bands. Now, here we can see on the dial that it's measuring 0, and actually when I stretch our kinesiology tape, I've got three pieces of 2-inch or 5-centimeter kinesiology tape here. And when I stretch, the dial actually there doesn't move from 0. There's no significant resistance through range whatsoever. If I keep going and get to the end point, we should see that the dial is starting to go up, but the tape can't actually stretch any further. So I've hit a restrictive end point. So that may be useful for trying to block some movement at the end of range, but it means that we're really not getting a lot in the way of deceleration and resistance through range while still maintaining full range. Because if I want to get resistance through range, I've got to apply the tape with the muscle or the joint in a short position to act like a bungee cord and give you this deceleration, this load absorption, this spring back the other way. Now, if we compare with our dynamic tape, this time we've got 2 layers of 3-inch tape. So the equivalent amount of tape. First we had 3 layers of 2-inch. Here we have 2 layers of 3-inch. So the equivalent amount of tape. And what you'll see is if we look at our dial here, as soon as I start moving, we start getting resistance. There's 4.4 pounds or a couple of kilograms straight away. If I go a little bit stronger or a little bit further, we're up to 6.3. Now the interesting thing with dynamic tape is it's viscoelastic. What does that mean? It means its stiffness is dependent on the rate of strain. In other words, the faster we stretch it, the stiffer it becomes or the more resistance it provides. So if I go a little bit quicker, now we're up to 16.2 pounds of force. If I go much quicker, there we have nearly 26 pounds of resistance or force. But as you'll notice, there's not a lot of stretch occurring on the tape. This is happening very quickly each time the tape lengthens just a little bit. Now, as I say, it's viscoelastic, so the faster we move, the more resistance we get. So if you're going over on your ankle, or you're running, or you're jumping, or you're throwing, you'll get more resistance and more deceleration because of the nature of the tape. You will also notice that there's not much in the way of an end point, and that allows us to get the tape on in that short position and then still get our people through full range. So we get that bungee effect and that recoil effect occurring. So very, very different physical properties used very, very differently. Now let's give you a little bit of a benchmark to compare against. So here we've got a resistance band in here. In this case, the blue in this particular product is the extra firm level. And let's just see what happens here. So we can stretch that one out, and we're hitting about 7 pounds of force. Okay. If I go quickly, we're still 8.9 pounds of force. Okay, 12.5. So we're comparing that. We were getting 26 pounds, about 12 kilograms of resistance with the double layer, the 3-inch tape, the dynamic tape. Here we're getting less than half, or about half of that amount. Okay, so we can see quite different different properties and used for different purposes. So this also just gives you a quick, I guess, visual demonstration of the difference. So this is just a skeleton here. He's got some bubble wrap around the top and bottom of his arm, so that we're not actually attaching to bone here, where we're attaching to the soft tissue, if you like. The bubble wrap's free to move. This particular thing is just a quick, light-hearted demonstration. It's not like we're doing it for some of our other things that we do, where we're actually really looking at trying to mimic a technique. But you can see here that with no tape on there, the arm's just going to hang down under gravity. And if we're trying to create a punch, nothing really happens there. It's just going to flop back down. So we'll then come in with our tapes. So here's a rigid tape. Obviously, that's going to change the resting position quite a lot. But we now have limited our ability to flex, and there's not going to be any recoil effect. So we're not going to get much of a punch unless we use the shoulder instead of the elbow. So with a kinesiology tape, you can see here we're actually passing across the joint in this particular case, put on in a sort of mid-range position, if you like. So we do get a little bit of change once it hits that end point. It's going to start blocking movement a little bit there. So we do get a bit of a change in the end point and a little tiny bit of recoil there. As we saw earlier, that's less than 100 grams there on the radar. That's what the setting was set at, compared to sort of 15 kilograms or more. Now here, if we put it on in inner range with considerable stretch on it, we can create that nice restriction or change in motion, a little bit of a spring back if we've got it in that position, but still not a great deal of deceleration through motion or strong recoil. Now here with the dynamic tape, you can see the resting position's changed immediately. We put it on in the short position with some stretch on the tape, and you can see that holds it up there against gravity, but still allows movement to occur. So again, you see as we bring it back, we can get through range, and then we get this strong recoiling effect to basically act like a second muscle, if you like, to give us some of that assistance. Okay, so we'll just run through a few of the different ways in which we can use a tape and some of the research that's emerging with regard to that. The first is sort of what we've been talking about so far, which is the basic physics of it, basically, so that if we can apply the tape externally to do some of the work, then we reduce the work required by the body or the parts of the body that was doing it beforehand. So this just shows our vector addition or vector summation, if you like, that if we have two force vectors in the same direction, they're going to add up, and if we have them in opposing directions, then they're going to take away. So if you think about it in really simple terms, if you hold your arm up and your elbow at, say, your shoulder at 90 degrees of flexion and your elbow at, say, 45 degrees, then gravity is exerting an acceleration on the mass of the arm that's making the elbow want to extend or the arm to drop down. And that force then needs to be overcome primarily by our biceps and our brachialis in that example to resist the arm from going down, or increase to overcome gravity to lift the arm up. So if we can have the tape provide some of the resistance, then that means that the muscle has to do less work. So there's less eccentric demand on the muscle. And then again, that energy is stored at the end of range, and that can assist in that transition to start that flexion moment as well. Okay. if we use the tape as a resistance, then obviously we increase the work of muscle as we have to push through the tape. We mentioned in that video there how the dynamic tape is viscoelastic, so the faster we stretch it, the stiffer it becomes, which is important. So if people are moving quickly, they'll get more force just through the properties of the fabric. And just again from the physics, the amount of elastic potential energy stored is roughly equal to the work it takes to stretch the tape. Now, generally, we're using momentum or inertia, if you like, to create the stretch, and then so that sort of doesn't have a high energy cost to it, and then we get that energy back into the system afterwards. Okay, there are a few studies, that show that. It sort of sounds like common sense, but this is a pilot study. It's not actually published, but it was done in Germany. I think he had about 40 subjects in the end, and he just cut a 2-inch piece of tape and ran it on the palmar surface of the fingers and along the palm and up the forearm with the wrist in flexion, and he measured the EMG activity in the extensors to hold the wrist and fingers in a neutral position, and showed that there was increased EMG activity required to basically overcome the resistance of the tape to hold the hand and fingers in that neutral position. Interestingly, if you do this with the tape applied with the wrist and fingers in extension, so in the lengthened position, and you measure the EMG activity, it's no different to not having tape on. So again, if we tape in the short position, we create the resistance. The muscle has to work harder to push through that resistance. If we tape in an extended position, then it's like our bungee jumper, once again, jumping from the helicopter with a long bungee rope. We don't get any mechanical effect out of it. So this idea of force contribution, can we just do some of the work? This is a video of a fellow who had a radial and ulnar nerve injury from a knife wound. And you'll see here that as he tries to extend the wrist and fingers, he doesn't get much in the way of wrist and finger extension, gets a little bit of overflow into sort of rotation and pronation. They then tape him in a couple of different ways, one to look at the finger extension and then another to look at the wrist extension, and you'll see the different results. So you see here without the tape, you see that thumb also adducting and coming across into the palm. And so the first part is just trying to change that finger extension, and you can see the change in position. They have actually run the tape up over the wrist as well, but it wasn't applied across the wrist with a lot of tension or in a really short position, primarily because it was the first time they'd applied it, and they were a little bit concerned about the skin integrity with such an amount of stretch going across all the joints. So, but you can see that there's this nice change in finger extension in the resting position, and because he has active flexion, you'll see in a moment when he goes to flex that the tape will then just spring back into extension quite nicely. Okay, so now they've taken it off the fingers and just applied it to the wrist in a bit of a figure-8 sort of configuration here. And you can see the resting position has changed immediately. So rather than, just flopping down in full flexion under gravity, the tape is providing significant resistance to that, and he's resting sort of around about that neutral position. Now, they haven't taped the fingers here, and because it has no active finger extension, the only way to get extension is to actually, flex the wrist and sort of use that tenodesis effect. So you'll see as he tries to extend the fingers, he's going to flex his wrist. But when he doesn't worry about the fingers, you'll see nice wrist extension. Now, ideally for this person, you would have a combination technique that looked at both finger extension and wrist extension, in which case you wouldn't need to create wrist flexion to get finger extension, which is what's going on here. Okay, but just doing the wrist and not worrying about the fingers, you can see there's nice spring back into wrist extension, or up to around about that neutral or slightly beyond. Okay, so again, it's not changing the nerve injury. Obviously, it still needs time there to allow for the nerve recovery to occur, but it does mean that functionally there's an immediate improvement. It may also mean that the wrist is going to get less stiff, or wrist and fingers perhaps, because we're going to have more movement more regularly. May swell less again because there's more movement. Maybe less pain again with more normal afferent input, if you like, coming in through the system and so on. So there can be a whole range of added benefits, as well as just an improvement in function straight away. This is another one that was recently sent to us as well from Brazil, this time obviously in another neurological patient with increased sort of tonal patterns going on. And again, you can see the wrist resting in that very flexed position, the thumb across the palm once again. And as they try to lift up as well, difficulty with the elbow flexion, unable to weight bear through the hand because of the wrist and finger position. So here with the tape, you can see immediately sitting in a lot more extension or a lot less flexion. The thumb's out of the palm, and they can now, this is with quite a light taping job as well, they can actually get some weight through, can create a bit more of a functional position for the hand to create a grasp, can actually get some elbow bending going on because of a little bit of a break in that pattern that was going on beforehand. So again, immediate changes in function, can perhaps practice the correct technique and get hopefully some more motor relearning going on as well. So this is another study that was sort of looking at similar sort of thing. Again, can we just simply do some of the work externally and thereby reduce the work requirements or the workload on the body? This particular technique is applied with the shoulders shrugged into elevation, and the tape runs from essentially deltoid to deltoid, so that when the shoulders drop down, again, the tape is stretching using sort of your cervicothoracic junction as a bit of a fulcrum point, and we get a force back superiorly, or basically to carry the weight of the shoulder girdle. And this was this was sort of a case series on people with work-related upper limb disorder, so neck and arm pain and sort of computer operators, if you like. And that group has been shown previously generally to have an increase in activity in the sort of cervical extensor muscles, both during an activity, a typing or a mousing activity, but also in preparation for it. They sort of compare resting the hands in the lap to resting the hands on the desk or on the keyboard, and also afterwards as well. And so what was found with this pilot study, unfortunately they didn't copy that particular methodology, but what they did show was that the muscle activity in those cervical extensors was significantly reduced after 48 hours of having the tape in place. So again, just by doing some of the work externally, it seems that we can reduce what's going or the work requirements of the muscle, particularly in the case where the muscle is overactive. And that can then have immediate functional improvements and improvements in pain as well. So this was a thesis that's published online, and this particular person had accessory nerve injury post lymphadenectomy, and they showed nice improvements immediately with active abduction of the shoulder against gravity, and reduction in pain as well. So it may be in part due to the recoil of the tape or the assistance of the tape on the shoulder abduction, and I think that could be increased by continuing that tape or starting that tape much further down the arm. But also there may be an element there of improving the postural stability, or the proximal stability rather, of the scapula by bringing them into a more upwardly rotated and sort of retracted position, and helping to maintain them in that position through the resistance of the tape as well. So which may then allow them to engage a little bit better and use the arm a bit better. Okay, so some simple examples of how we might use that force contribution idea is if somebody's weak, we can just assist them. If they're overloaded, can we do some of the work for them? The first photo there is, again, a neurological patient who had a sort of flexion sort of patterning and wasn't able to do that cone task, moving from one side to the other. So they've essentially just come in and helped in every aspect where it was required. So they brought in some wrist and finger extension, actually spiraling around to bring in some supination. There's also some elbow extension, and then there's also some shoulder external rotation. And with that tape on, she was then able to do that task. So again, can practice the correct technique. Hopefully, there's some carryover there from a motor relearning and skill acquisition point of view, as well as obviously the immediate improvement in function. You can see there in the tennis, this one is passing around the arm and across the back of the shoulder joint. So as they swing through in a follow through, particularly from an overhead or from a serve, that's going to create a deceleration to that follow through to reduce the load, particularly in that posterior capsule. Then the other two, we're looking at some wrist sort of extension type techniques here. Again, we saw that energy storage and recoil earlier, and we've just seen a couple of videos on how that sort of thing can assist if there's weakness. But also we can sometimes use this in some of our lateral epicondylalgia type patients, who, particularly those who have just gone and first episode, and maybe it's springtime and they've gone and prune the rose bushes or something, and used a lot of gripping type techniques and just overdone it. So this can come in and actually do the work of those wrist and finger extensors for a few days, just to allow things to settle down, and then obviously reintroduce the load in a way that they can manage it. But also with appropriate education, by coming off the two fingers there, we can also discourage them from using their thumb and their index and middle fingers for strong sort of power gripping type activities incorrectly. Obviously we prefer them to use the ulnar sided fingers for that, and use their index and ring fingers for those manipulation, fine motor type tasks. So again, if we explain to the patient that, and take them to help them stay out of that flex position, or discourage them from flexing, that acts as a really good reminder as well. And then the last photo there is just for a Dequervain's. So again, with our tendinopathies, there's a lot of research showing that a combination, particularly of tensile load or overwork with compressive load, will bring on tendinopathy most rapidly. A lot of work from Soslowski's group, Sean Docking, Jill Cook talks about it. And so what we can do here is we can do some of the work of the extensors and abductors of the thumb to reduce some of that work, if you like, or tensile load. And then we can also come in and box up the tissue around those tendons to perhaps reduce some of the compressive loading aspects of it as well. And I'll talk a little bit more about that as one of the other mechanisms in a moment. So here's another example. This is somebody who had a lot of restriction and stiffness post-operatively, I believe, and they've done their manual therapy and other techniques to regain some range of motion there, and then they've used the tape to try to help maintain that and resist them, again, just spending prolonged periods in that more flexed position. So you can see there that it's helping them to stay in more extended position of the fingers and wrist. Okay, so that's just contributing force. Can we do some of the work externally? Are they weak? Are they overloaded? Is the tissue injured, a muscle tear, a tendinopathy? Can we just get in there and do some of the work to take some load off directly? The next thing is just modifying movement or position. So this is what we talk about more as an indirect technique, particularly with regards to load. So we're not directly doing the work, but we're now changing movements which we know load up various structures, for example, or we may be changing the way that they're loading a joint by changing a glide, say a mulligan type technique. Something like this photo of the wrist here is a sort of a derotation technique for our TFCC injuries, and that can give immediate changes in pain and improved ability to weight bearing extension and those sorts of things. So we're often looking at trying to move people into a position of ease and then taping them into that direction, but also just maybe gross sort of movement patterns as well that we're looking at changing. So not particularly worried about a particular muscle or musculotendinous unit, as is the case with the force contribution, if you like. And there is some emerging research on this, not in the upper limb at the moment, but interestingly the hip, which from a taping and mechanical point of view sounds quite difficult. There's a lot of soft tissue, so getting purchase on the levers is quite difficult. And yet we still see some really nice changes. So this was recently presented at the International Olympic Committee Injury Prevention Conference earlier this year. And what they looked at here was female volleyball players doing a squat and taping them to resist them collapsing in at the hip and consequent sort of valgus at the knee, which again is sort of implicated in a number of different conditions. And what they showed, along with a couple of other studies that are underway at the moment, which I can't talk too much about as they're not published yet, but we're seeing that we can reduce both the magnitude and the velocity of that frontal plane motion, or that hip adduction, if you like. As I say, there's further studies coming that hopefully will be published before too long. Okay. Again, particularly with these newer studies coming out in Australia, what they've compared is taping with the hip in the short position. So in this case, that's extension, abduction, so abduction, and external rotation. And they've compared that with just taping in a relaxed sort of neutral position, just a normal standing position. And they've shown that only when you tape in that shortened position with significant tension, or when substantial resistance is created by the tape, will we get an effect. So we need to get it on in that short position to create that resistance in the tape, and therefore a change in the mechanics. Now, if we can change movement, then we can have, or position, we can have a number of other effects. We can affect the length tension relationship, for example, of muscle. So if we look at our diagram or our photos here, or actually if we turn your attention initially to the diagram on the right, just as a refresher, that's our length tension curve. And you can see that we have the actin and myosin filaments there. And basically in mid-range is where we have the best capacity to generate force. So we have optimal cross-linking of our actin and myosin filaments to create tension. If we're in a shortened position, we've already cross-linked most of those muscle fibers, and therefore it's hard to generate more force. And if we're in a lengthened position, we have minimal cross-linking occurring. So again, it's hard to get those actin and myosin filaments to sort of ratchet together to generate force. So if we then look at the first picture here, we can see that the scapula is essentially in a downwardly rotated position and been anteriorly tilted. So you can see the acromion is dropped compared to the left side. The inferior angle is wider, and so on. And so from a length tension perspective, our lower trapezius is trying to operate in a more elongated position, and therefore has a poorer capacity to generate force. Not only that, but there's more force to overcome, because in this downward rotated position, the orientation of your glenoid is such that it doesn't really offer any passive support to your humeral head. We also tend to shift the arm forward off the base of support. So from a leverage point of view, there's a longer lever arm of gravity acting on the arm. So it's actually more work that the muscle has to overcome. So what we've done here is with the arm in flexion, run from the sort of just proximal to the elbow up over the shoulder and then down, with the scapula also in a more upwardly rotated and retracted position, such that as the arm drops back to neutral, the tape tensions provides a force vector back superiorly on the arm to create a lifting, unloading type of effect, and then also coming across the back to resist them from downwardly rotating. And so from the length tension point of view, the muscle now here, the lower trapezius, is acting in a more mid-range position, so has better capacity to generate force, but also we have less work to do because we've taken some of the weight of the arm And also by correcting that scapular position, we've also provided a little bit more passive support and a shorter lever arm of gravity acting on the arm. So there's less work to do and a better capacity to do it because of that length tension position. Okay, and so this just shows you a couple of examples here, and we've just sort of called this a mallet finger. There's not actually anything wrong with this one, but just showing you here, and this will become apparent when we talk a little bit about developing techniques as well. But in this first photo, we have both the PIP and the DIP in extension, and we're crossing both of those posteriorly, and so we get an extension moment at both joints. In the second one, we're crossing the DIP posteriorly, but the PIP in flexion and then crossing anteriorly. So we then end up with a flexion moment of our PIP and an extension moment of the DIP. So this can be useful perhaps under a splint if somebody's tending to hyperextend at the PIP, possibly in a transition out of a splint if they still have a little bit of a lag, you know, at that 8 weeks or so, then you may find it useful to tape them to help them maintain that position. And then again, this is a positioning correction here. So basically we're resisting the wrist from going into a lot of flexion or horizontal flexion, probably more correctly, and holding that thumb back out and across as well, so that we're trying to discourage positions that compromise that carpal tunnel. Here we have a couple of alternatives for our first carpometacarpal joint. The first one is, again, resisting that deformity of the thumb coming across the palm. And also we have this force here which provides a direct resistance to that subluxation sort of posteriorly and radially. We also are sweeping around, and so we actually have a force vector proximally as well, which also helps to provide some force closure, which I'm going to talk about a little bit more to help stabilize. In this second position, second photo, what we're looking at doing is creating a rotation technique on the thumb. So often with those, you might find that when they squeeze, they're quite painful if they're pinching or gripping, but if you provide a rotation force, then they do it. It's much improved, if not taking that pain away completely. So then if that's the case, then it makes sense to maybe we can mimic that effect with the tape by creating that rotation. The last two are using our Posture Pals products, which are the same material as in the tape, just in a couple of pre-cut versions that can be used in a few different ways. But again, to provide better postural position, better proximal stability of the scapula and so on, which allows them to then function more optimally with the upper limb. Okay, and here are a couple of examples that have been sent to us in the past. Again, just to position functionally. So as we saw earlier with a fellow with the nerve transections, that we could get the fingers out, we could get the wrist up to create a more functional, more useful hand, so he has a more functional grasp. But also here, you can see working on some of the key points, getting the thumb out of the palm to perhaps help break certain patterns and so on can be quite useful as well. Right, so the next one is force closure. I started to mention it there with the carpometacarpal joint. Now, you may be familiar with these terms. We often throw them about more with the pelvis. And so basically, form closure is talking about the stability essentially that's afforded by the architecture of the joints and the passive connective tissues. So in the first diagram there, you know, that's a stable structure from a form closure point of view because the force of the block on top is resisted by the two acting underneath. And so that's nice and stable. But if we move to the middle diagram, the base of support has been moved slightly wider, and now there's nothing directly resisting the one at the top from just dropping through the middle. But in the final diagram, we now have a force coming in from the sides, mediolaterally, if you like, and that is going to reduce the will prevent the one in the middle from dropping by basically increasing the coefficient of friction at those joint surfaces, those articular surfaces there. And by creating that increased friction, it allows us to maintain that in a more stable position. And so generally that force, that's what we would term force closure, and that occurs through our muscle contraction generally, so contracting muscle onto the joint capsules, onto our ligamentous and tendinous connections, and that can create that compressive force at the joint surfaces to help stabilize. But we also can apply it externally. Our sacroiliac joint belts are an example of this. But as I mentioned on the first CMC joint, we can also use it for a variety of joints to help augment that stability. And there is some preliminary research coming out. This was just presented just a few weeks ago at the Brazilian Sports Physiotherapy Congress. Again, unfortunately, it's on an ankle, but the principle is the same. And so they looked at taping the ankle with dynamic tape in elite volleyballers with ankle instability, and they looked at a range of balance measures, functional outcome measures as well. And they showed that not only they had improved reach distances and so on when they were doing these balance tasks, dynamic balance tasks, but it also improved a couple of the outcome measures and subjective sort of outcome measures, the Cumberland Ankle Instability Tool and the Functional Ankle Ability Measure, doing that. So again, part of that may be that force closure mechanism, because the technique that they used goes circumferentially around the ankle to create that compression. It provides resistance to them going over on their ankle, so it provides a deceleration, and perhaps that increases their the time they have to react, if you like. Okay, so here's a couple of examples. Again, we mentioned the first CMC joint, so we're getting this compression to sort of approximate the joint and help stabilize it a little bit as well. Some of our carpal instabilities, our scapholunate and things like that. This particular technique is coming from one side around the wrist circumferentially and then emerging and coming back up the other way. And so we end up with triplanar compression. So we end up with a force vector coming approximating the joints, as well as mediolaterally and AP from that circumferential one. Also with this, we tend to apply it in a bit of extension. So as they actually flex the wrist, where this is crossing is right over that scapholunate region, again providing a bit of a barrier to posterior sort of shearing, if you like, and that subluxation. And then in some of our finger applications, again, we can have this compression coming approximating, as well as we can provide resistance to medial and lateral forces, but we also are getting some compression or approximation to help stabilize from that force closure mechanism. Okay, and the last mechanism that I want to just talk about quickly today is this idea of a soft tissue offload. So this takes us away a little bit from the mechanical idea of managing mechanically the motion of joints or the work on the muscle by decelerating a joint motion and so on, and looks more at the mechanical effect on the tissues themselves. You can see that photo there, how everything's bunched up into a big soft spongy area. You get that sort of orange peel type effect going on. And we've done this for quite a long time with our rigid athletic tapes. You might have done some box taping type of ideas. Jenny McConnell coined this sort of a diamond box on the lateral elbow for our tennis elbows, and created this box around the lateral epicondyle. And actually, I think Bill Vicentino some years ago in some of his commentaries on tennis elbow had talked about some studies there where they showed an improvement in pressure pain thresholds, as well as in pain-free grip strength and so on in the tennis elbow population by creating that boxing type effect on them. More recently, sort of towards the end of 2014, Hug et al., which was also, I believe, Bill Vicentino and Paul Hodges from memory, they used elastosonography, so essentially ultrasound, to look at the tissue stress when box taping was applied. And they did it on the quadriceps muscle, and they were using your traditional sort of coverall and rigid athletic tape to box up around the quadriceps muscle. And what they showed was that they had this reduction in tissue stress with the box taping on there. And that held true even when the muscle was contracting, except when it was in its shortest position in full inner range. But throughout range, it was maintained as a reduction in stress on the muscle fibers. So that's obviously going to lead to potentially a change in pain, because it's not going to be putting the same stimulation on sensitized nociceptors. But also, you know, if you think of your muscle tears, obviously that's advantageous early on, where it may reduce not only the pain but also the bleeding and so on associated with that. We mentioned earlier our tendinopathies and so on as well. And so that's that combination of tensile load and compressive load. So again, we can do some of the work, in this case, again, on the thumb, to do or reduce the workload component or that tensile load, but we can also create that boxing effect. And you can see it there even just from that V that's created by that initial strip there, to create this boxing up and this soft tissue unloading. Now we can come in and create a V the opposite direction, or do various other things to enhance that effect, but you can see it occurring there. And this is quite different from what we do with our kinesiology tapes, where we're getting convolutions in the tape and lifting of the skin and all that sort of thing. You can see here the tape's not bunched up at all in any of those photos here either. So basically we're still applying the tape with the body part in the shortened position and the soft tissue and muscle as relaxed as possible, and then we manually gather it up with our hand, with our fingers, to shorten it up as much as possible, and then hold it in that shortened position with the tape to get this boxy, soft, spongy sort of effect on there. The other time that you may find this useful is with some of the mechanosensitive neural tissue. So if you're looking at your upper limb tension tests or your neural tissue provocation tests and that sort of thing, we know that the nerve, when they're sensitized, they don't like stretch, and that's generally what we're testing for with those types of tests, but also they don't like compression. So we have that mechanical allodynia of the nerve, and so palpation of the nerve generally will reveal that the affected side is more tender than the non-affected side. So we can come in to tape them to discourage them elongating that sensitized nerve, to help try to dampen down the system by not continually overstretching it, if you like. But it may also be useful to come in and box up around where the nerve is being irritated, or where it may be getting some compression and so on. So again, there are lots of ways to do it. Here we're looking at sort of a posterior interosseous branch of the radial nerve, but we can tape above and below it to create that boxing effect. Sometimes we can create a cross straight over